forceps or grasper or something, so that it is not going to, not allowing the reamer to come intra-articular to the femoral condyle or PCL or many structure inside the knee. So in this way you will avoid this. You can see this is going to hit on the PCL side or something like that, or femoral condyle if it is in this direction. So now you can see this is just coming from where its medial tibial spine is getting started, just lateral to the medial tibial spine, in between the medial tibial spine and the lateral tibial spine. So this tibial part is done. After doing this tibial part, lot of fluid come from the joint outside and your vision becomes blurred.
Get a curate. Sorry.
Get a curate. All your artery forces will become poor after 10 seconds. जितना artery forces पकड़ोगे फुल घूमेगा. अब artery forces क्या? तो एक curate ले लो.
Yeah.
ऊपर से दबा.
Either curate or artery forceps.
Curate always. जब तक ये जो रिमर का हेड बोन के अंदर नहीं जाता, just lift the skin like this. Simple. Till the rimer head has gone, because तब तक ये चौड़ा है, स्किन को रगड़ेगा, छोड़ दो. डेड बना देता है, घाव हो जाता है. कभी करना है, ये नहीं करेंगे अभी के. Just lift it. बोन के अंदर क्या हटाओ इसके वाइप के ऊपर. बेसिकली प्रैक्टिकल टिप्स है, इसमें कोई माने ये लिखा हुआ नहीं है कहीं पर, इसका कोई लिटरेचर नहीं है, बट ये प्रैक्टिकल टिप्स मुझे बताते हैं. और कुछ
So there will be lot of fluid will be coming from this tunnel and your vision will be blurred. So in that case you can take a plug, either that needle of URP set you can put here, or there is this block, tunnel block is there, you can insert in that, so that fluid stop coming from the joint. So again now you will come on the femoral side. So femoral side that we have discussed, your scope is coming something like that. So this is your scope, that is coming something like that. So many a time it's become difficult to see the complete posterior part of the femoral condyle. So you can see from the medial side whether this complete femoral part is clear or not. So after seeing that, you can make a point with the help of this microfracture all. With the help of microfracture all, you can make a point there. So microfracture all something will be something like that, but it is little bit tilted. So you can make that hole there exactly where you want to come. That is one thing, and this hole will be there. So this hole will be there, and in this hole you can put the beach pin and then ask your assistant to do hyperflexion, something like that. Scope will be there only. Scope will be something like that. You are seeing there. Okay. Or another thing, you can take the help of offset. So offset calculation is also again very important. You want 2 mm of your posterior condyle of the femur left. Suppose it's 8 millimeter graft is there. So 4 millimeter will be anterior to your that point and 4 millimeter posterior. 4 millimeter plus 2 millimeter of your femoral cortex. So 6 millimeter of the offset you have to use. If it is 10, then 7 millimeter, something like that. So in this way you can
be like that. Graft diameter by 2 plus 2.
Plus 2.
10 diameter is 10, 10 by 2 is 5 plus 2. Plus 2 is for your posterior wall.
So this is the accessory anteromedial portal, that is low and medial, or from here you will come here and your tibia will be hyperflex, leg will be hyperflex. So in this position this is your offset, you can come with the help of offset. Yeah. Really? So this comes over the lateral side of the femur. So Rajiv da, from extra-articular side, where you want to pin this pin to come outside over the lateral condyle of the femur?
I think over the center of the iliotibial band. That
Yeah,
is the ideal
perfect.
point.
So ideal is, Rakesh boss is also agreeing that it should be in the center of the IT band. It should not be too anterior. It means your tunnel is anterior. So this thing you can find from extra articular side by seeing it. If it is in the center or at the level of this, your trochlear groove is getting finished, it means your position is exactly fine.
Basically, you will not get it in live patient. It is just a bone there, and it is next to 170 degrees. So if it is live patient, there is a calf muscle. So you won't want your 140 degree or
110, 120.
110. Just ऐसे करके पैर से उठा लो या मोड़ लो. That is good enough. And if it is that there, you won't go that vertical because it is just a bone now. Bone को ऐसा मोड़ दिया, इतना कभी मोड़ ही नहीं सकते.
If the exit is slightly more posterior, do we accept it?
Yeah, so if exit is too posterior, then you should look from the intra-articular side. If its position is clear, at ideal position, it means your knee flexion is less. Your wire is little bit horizontal. Suppose you can start from the hair only, but if you go like this, इसको drill करो थोड़ा. डॉक्टर अनंत जोशी के चेक एक्सरे में आप देखोगे हमेशा ये टिबियल टनल का जो ये पीछे रहता है हमेशा. Most of the, because what sir says, flexion is not needed more than 90 to 100 degree. Is the philosophy of the sir.
But he uses most of the time he uses flexible.
No, recently, but initially, see if your knee flexion is 90 degree or lesser. देखो ये पीछे आ रहा है आपका थोड़ा सा, या और मे बी लेस मोर पोस्टीरियर. सो इफ योर टनल इज फाइन, so no need to worry too much if it is until not in the complete posterior compartment.
One more point.
Yeah, निकाल.
Many times to create the anatomical femoral
इसको
tunnel,
निकालो ये ठीक.
many times to place the direction of your femur parallel to the floor, and in those cases you will end up with the tunnel slightly posterior or almost on the back side of your condyle.
Yeah, that's why I'm saying. So in that cases your knee flexion is not more than 90 degree. If your knee flexion is more than 90 degree, you will always something like at the 90 degree of lateral femoral condyle.
So the retrospective way, if the tunnel is on the posterior aspect of the femoral condyle, is it going to hamper or is it acceptable?
So as we have discussed that it's not completely posterior to the posterior cortex of the femur. If it is intra-articular,
you need to have at least 2 millimeter away from the articular cortex. At least उससे नीचे आप जा नहीं सकते. अगर यहाँ स्टार्ट कर रहे हैं और आपको लगता है कि अगर posterior cortex ब्रेक कर देंगे, that is another thing that we can discuss afterwards. तो फिर बात है. लेकिन एक ऑपरेशन के बाद normally we go a bit higher. डर के मारे हाथ नीचे चला जाता है, वीडियो चलाता है, डर के मारे बहुत चीज होता है.
Also the guide wire is coming through the posterior aspect of the knee. You can check under the beach है ना, putting the scope की अंदर भी कहाँ से गया है.
बच्चा लोग कभी शुरू में गड़बड़ नहीं हो ये जानना जरूरी है. ये तो प्रॉब्लम सॉल्व करने के लिए गुर्दे भी नहीं, लेकिन अभी गड़बड़ नहीं हो. सबसे इम्पोर्टेंट है कि पहला 10 केस मेरे कहा नहीं, and then you have follow the confidence. पहला 10 केस मेरे कहा नहीं.
so next is your 4 mm reamer. So 4 mm reamer having this marking, how much you are going inside. So one thing is that you can ream with 4 mm and you will have marking there. Once this second cortex comes, so you will know how much of this tunnel length is. Another thing, किसी चीज़ से पकड़ो इसको. And after that your cocker should be there. One thing that length will be according to your reamer part. Another thing you have depth gauge. So you can go here and you can just measure the depth just like you are at the time of this drilling for the bony fixation thing. So here you can see this length is almost 35. So this is the ideal length of femoral tunnel in most of the standard population. Until is not very short or not very bulky guy. So anything in between 30 to 40 mm of the tunnel diameter is perfect. If anything 40, more than 40, then again you should think that you are, whether it's not going to be non-anatomical, and if it is less than 30, then chances of the horizontal graft, like that Dr. Manish was telling, that it is horizontal thing, more posterior thing is high, less than 30. So in between 30 to 40 it's fine. And once this part, your measuring part done, then you can use either fixed loop or variable loop. So Rajiv da, fixed loop or variable loop?
Variable loop. Now I am setting variable loop.
Rakesh was?
Now almost very.
Variable.
Almost.
Sunit da? Fixed loop, still fixed loop?
Yeah.
That's great. Any reason?
Yes, fixed loop.
Any reason, a strong reason?
Yes,
There is so many complaints coming from the adjustable loop. In a big shot, those who are doing with the adjustable, now they are totally shifted to the
A strong reason.
All the big shots are here now.
Rajiv boss is the big shot.
in my hand,
Giving appointment to the patient after 1 month or even more than that.
because it shows that there is loosening of the adjustable.
Okay, so one of the reason of variable loop, there is some chances of loosening of that loop. Rakesh boss.
हाँ मतलब देखो अब वेरिएबल लूप का बहुत लोकल लूप मिलेगा सस्ता मिलता है तुमने तुमको कहाँ पता है तुमको बता के मत बता के लोगों के ऊपर बड़ा मुश्किल हो जाएगा मिलता है एंड उसका जो लास्ट लॉकिंग होता है उसके बाद मिलता है जो इफ यू आर डूइंग दीस पीपल तब तो बहुत प्रॉब्लम होता है इंपॉर्टेंट थिंग इज दैट वंस यू हैव फिक्स्ड द टिबिया you go back to the femur again will get to the
Retention.
side.
Yeah, you can do
And
that retention.
at least whatever loosening is there, you can finish it up there. 5 millimeter.
So there is advantage of fixed loop and advantage of variable loop. Fixed loop means you are not change the length of your loop, and variable loop that you can adjust, you can shorten the loop, whatever the. So fixed loop, if it is less than 30 mm of the tunnel length, again sometimes it's become difficult to use. So that is one of the this fixed loop using. But there is some report that this may get loosened. But for last almost 13-14 years from sports injury center to here, I am using this variable loop.
दूसरा बात ये भी तो है।
Luckily, I don't have so much of problem.
दूसरा बात तो ये भी तो है if you are having fixed loop देव के पास restore loop रखा हुआ है हम लोग के पास नहीं रखा है भाई एक ही से काम चल जाता है so the thing is that you get one loop and you can fix any side
I think the advantage is smaller tunnel and second
and
advantage is you
second
can
important,
tighten it.
second important thing is that you can easily get a quadruple
With
graft
that shorter graph
with
can,
adjustable loop. Getting a quadruple with a fixed loop
is very difficult.
थोड़ा सा हाँफना पड़ेगा हमको
क्यों सर? फिर आपको घींच करके नीचे लाने में घींच के नीचे लाने में अगर उतना छोटा हो जाता है बिकॉज टनल आपके हाथ में नहीं है इफ इट इज बिकम्स 30-35 आप क्वाड्रुपल कर देते हो तो फिक्स्ड लूप इफ यू आइदर यू टेक 35 आपके पास रहना चाहिए मैंने 30 का फिक्स्ड लूप रहता ना हम लोग 15 के 20 मैक्सिमम रखता है 15
So
आपके साथ तो कभी नहीं होगा
So, Arthrex-
प्रॉब्लम होगा नया वाला हम लोग के साथ करने में क्या
So,
चला जाएगा पीछे
so Arthrex people is saying they are making this this tightrope for last 21 year and supplying all over the world, and hardly any this problem with
And
that.
the next gold standard in the knee is the adjustable loop tightrope.
Okay, so that will be the part of this. So
आप कमेंट में खोजिए ना कमेंट में खोजिए बस बात करते
yeah, definitely there is reporting. Nobody is denying it. Nobody, because I have seen this loosening of loop in the AC joint. I have two cases. I have two cases of using AC joint tightrope, and both get loosened. Recently one. Yeah, definitely. That's why now I am believing that. Initially I don't have any belief in that, but now I am believing that it may be one of the possibility that this may get loosened.
बीच में भूल गया है तो बता दे रहे हैं जब एडजस्टेबल लूप में इंटेंशनली और इंटेंशनली इफ यू आर डूइंग इन अ प्राइवेट सेटअप यू आप 5 मिलीमीटर का बड़ा लूप बनाते हो अगर आपका वही फिक्स्ड लूप रहता है यू नो द स्ट्रेंथ यू कैन पुल इट आउट you will go exactly the same size.
Question is what is loop?
So again I have said that the fixed loop is there. So this is the variable, this is the loop over which you will load the graft thing. Your graft will come inside the loop like something like this. So this is your ACL and this is your loop. So variable यही use करना अभी उसमें use करेंगे. So this is the loop. So there is fixed loop and there will be variable loop. This loop is almost 50 रहता है ना तुम्हारा. So this is 50. Arthix people having this variable loop is 50. Your tunnel is 40. So now we'll go on that only. So this is the loop. So this will maybe fixed. You cannot change the length of this loop, or this may be variable one in which you can shorten the loop. So whatever the amount of graft you want to the inside the tunnel, and remaining part will be with this only, this loop only. So we'll come to that.
Left hand is graft. One point I just want to highlight is while using the adjustable loop, you are drilling the femoral tunnel first with the 4.5 mm drill bit. Those who are drilling and hand in the drill, drilling the hand, he has to precise over the control, so that once you are beyond the perforating the lateral condyle and you go inside, that means you are perforating the IT band. And you are using an adjustable loop, the chances are there your loop would be go outside over the IT band and you
So there is marking over the graft and
in spite of the thing that it may happen.
Yeah, it's happened with that. So once you will come to that, that is the side.
Does anyone practice putting a square knot after the final tensioning of the adjustable loop?
Yeah, I do. I have used when I am forced to use the adjustable loop, I usually tie the knot.
Yes, I usually do that. I put a square knot,
Yeah.
one or two after final shot.
can use the
So
shoulder
that
knot.
decreases the chances
So
of.
do you open that side?
No, no.
On the lateral
Just use a
side?
knot. Just use a knot pusher.
pusher.
How your knot will go there?
No,
So
no,
you have to open.
yeah,
You have to open that.
No, no, just try a knot. Take a normal knot pusher and push it through that same path. It reaches up
But
to
it
the
will be difficult. You have to open that. When you open that.
You'll be stuck on the
The knot pusher works as the.
Yeah, and you will be stuck over the IT band. I have did both with closed part also and after opening
Those
also.
patient is have pain on the lateral side of the
Yeah,
yeah.
yeah.
Pain is always there.
Yeah, it's always
Don't
risky there.
put the knot over the button.
So always use the fixed loop.
I put So that's good. Some people are from fixed side, some people are from variable side. That's good. So after this 4 mm reamer, suppose we are using the variable loop. First we'll discuss the variable loop, then the fixed loop. So for variable loop, you need minimum amount of graft in the femur, Rakesh boss.
18 to 20.
18 to 20, Rajiv boss.
15 to 28. Minimum 15.
15, Dr. Rita ji.
20 plus minus.
20, Sanjay boss. 20,
Yeah,
Manish.
father.
So 20, almost 20 is minimum, or you can go to the 25 or 30 depending upon the total tunnel of your femur. So minimum is 20. So suppose our graft is 7.5, so we'll take the advantage of 25. So here scope is here, you are seeing the marking over that, over the reamer, and you are drilling it. मार्किंग है कि क्या है?
मार्किंग स्कोप से दिखेगा, हाई से देखना बड़ा मुश्किल। वो तो मैग्नीफाइड हो जाता है ना।
मार्किंग भी मिट गया इसका थोड़ा।
नहीं वो स्कोप से दिखेगा।
अरे हम लोग जैसा लोकल डॉक्टर में तो उसको ही स्कोप नहीं दिखता है।
So this 25 we have read, okay, and then so this is the loop. This is the thread that used for raising of the suture. So this loop will be outside, and this thread end will be on the femoral side. So this will go outside, and this loop is outside. Now we will pull inside the joint.
Suture retriever.
And take it from the tibial tunnel that we have made. You can make the femoral tunnel first also, there is no problem, but only thing at the time of removing, many a time your reamer will come with this thread. Now you take the thread off. So this is off on the tibial side. Look at it. Marker? नहीं एक धागा दे दो हमको. So this is the graph that is over the variable loop. ये पकड़ो, एक धागा दो मेरे को.
पेन से हाँ पेन से तक बात पेन से तक
हाँ, पेन से बांध सकते हैं. या फिर धागा से बांध सकते हैं.
नहीं फाइल से पेन करेंगे तो किस तरह दिक्कत करेगा स्केल लेना स्केल
So this is the 25 scale.
तो कितना देते हो?
25. So this is the 25 here. So in variable loop you can make two mark. One is 5 mm lesser of that. You know. ये कैसे यूज कर लिया ये? और कोई पेन है किसी के पास?
जेल पेन है किस पास
हाँ
अच्छा चलो
ये हो गया.
मैंने बात समझ में आ गया.
So this is marking of 25 or this is at the marking of 20. 5 mm lesser than that. 5 mm lesser than that. This is the marking of 20. Okay. So and our tunnel was 40. So loop will be marked at 40 mm from the button side, not from this side. So that this button will go on the lateral cortex of the femur. So after 40, this will deploy over the lateral condyle of the femur. So we should be this much of only inside the tunnel. If you pull more than that, then this button will come over the IT band. That as Dr. Rita was saying, that part. So this is the 40 mm. Now this get looped over this. The rail thread, and from tibia side here you are seeing through the scope that your graft is getting this fiber wire of this fiber tape tightrope is getting over the lateral side. Now this white is for the loop
ये दिखना चाहिए.
and this blue is for the pulling thing. So once your blue is you are pulling, this will be longitudinal. Your button should not be the horizontal one at the time of pulling. So this is longitudinal. This is going little bit. You can take inside the joint. So now this is inside the joint. You can see it, and you keep pulling it.
ग्राफ मोटा नहीं हो गया.
नहीं ग्राफ कितना दिया था रीमा? 7 था. हाँ ठीक है, हो जाएगा. So you can see this marking is coming here, and as it comes over the femoral part, this marking नहीं ऐसे छोड़ो, एक मिनट छोड़ो. This is coming there. Just little bit more. As it is there, this up lateral side will come. You can see this button is over that. And if you keep pulling even after that, then very high chances of this button will flip over the IT band or it come to the skin part. So once this is done, you just pull the graft down. This will get flush there. So your button is flush over the lateral condyle of the femur. So now your graft is outside the joint. So this graft will be taken inside the joint with the help of this white suture that is inside the tightrope. So that is the advantage of adjustable loop. Now you will keep pulling this, just pulling one followed by another one. Once you are pulling this, इसको खींच के रखो था ना, एक हाथ से बटन. Since IT band or skin is not there, that's why he is placing the hand over button and one button to place. So loose choro na, tight not karna. And this graft is going inside the joint now. And you just pull the graft till the first mark. It means the 20 mm of graft is inside the femoral tunnel now. Okay? You left the 5 mm of tunnel still vacant. And at this point, you just come over the tibial side. Yeah. You just over the tibial side and do the cycling. This is for the tensioning of your ACL. You can do the tensioning of ACL at your board also with the help of tensioner. Rakesh boss, board or cycling?
No cycling. Cycling.
Raji boss?
Cycling.
Tarun?
Cycling.
Dr. Rita Dev? Cycling. So almost everybody is with cycling, and cycling is 10 cycling, full flexion, full extension. Full flexion, full extension. So 10 cycling of that, and after that you just fix either with the help of a screw, or if your graft is shorter, then you can take the help of suture disc also. So this is the guide wire. Again, this guide wire passing is very important. Many a time you must be seeing this screw is going too much posterior. It means the screw was not in the direction of your tibial tunnel. So always follow the tunnel direction. Your guide wire should be very easily passing through that, and also your direction should not be like this, not like this. It's very common at the time of placing the screw. So this should go very easily in the direction of your. And another thing is that one body has to keep pulling it, and your knee flexion should be 30 degree only, not more than that. And this sound is very important. This will give you the confidence that your screw is holding graft very tightly inside the tunnel. Usually, if you are using the bio screw, boss, size bigger. What is the size?
We have 2 plus.
2 plus, Rajiv boss?
It depends upon, you put your trocar in between the graft and the tunnel. If it's going easily, it's 2 plus. If it's going with difficulty, 1 plus. If it's not going, trocar is not going inside same. Depending upon the bone quality.
That's very good. So, it's the bone quality. If a strong bone, 1 plus. If you are using bio screw, if poor bone, 2 plus. And if you are using the metal screw, Rajiv boss?
Metal screw I am not using. Now HS.
Dr. Rita Dev?
I was not using metal screw.
Tarun?
Sometimes when I use 1 plus.
1 plus, still 1 plus, Rakesh boss.
I never use but 1 plus. I
Yeah,
used to use
so
one.
I started with same. So I started with metal screw. I almost in every case is using the same size, not bigger than that. Because many a time, if graft is even little bit of shorter, this ethibond get cut with metal screw. And also the hold with this metal screw is very great even you are using the same size. So you are inside this.
Till date, if you go, there is an ISACOS consensus that metal screw are the best.
Yeah. Lot of people are still doing this metal.
Against adjustable with against bio screw.
The other problem is not we get poor quality local made like this. They cut the. If it is, they normally cut it. I used to use it ACL when I am using the screw on both sides, and I am putting a screw 0 size of the tunnel, and all of a sudden I had half the tunnel in my hand.
When we have a Mindtech workshop, then I will tell you which company screw are the best, metal screw are the best.
So after that, take this guide wire out. It should come very easily. There will be difficulty only once your direction of a screw is not in the direction of tunnel. So take it out there and come again back on the femoral side.
एक बात समझ लो, if you are drilling in this position and you are screwing in this position, so your screw, you will feel the difference. कि ऐसे कर रहे थे, ऐसे कर रहे हैं. इतना बात तुम खाली याद रखना है. You are drilling in this position, angle is same, but now you are screwing in this position. So just keep in mind.
There are very high chances of malpositioning of your screw, not in the tunnel. So after that, you just come over the lateral side of your this femur and take this ग्राफ्ट भी दिखाना और ये भी दिखाना है। ये इसको होल्ड करो टाइम। टेक अगेन दिस लूप, दिस थ्रेड इन टू हैंड, and now again you can see this graph is getting shorter. So this much of the thread is out, loop gets shortened. So around 3 to 4 millimeter you can again tighten this ligament, because many a time at the time of putting this screw there is chances of laxity of this graft. So advantage of this variable loop is that you can again re-tension the graft. We'll come to the now fixed loop. If this would have been the fixed loop,
One question
yeah.
for the delegates. How much of tightening do you accept? What is the, how do you assess clinically by arthroscope, by visualizing it, how much of tightening you should do?
So tightening your graft should be filling your tunnel on the femoral side. On the tibial side you are fixed with the screw. It's not like you can create too much of tension inside the graft. It's not like that. Only thing is that at the time of this loop shortening, how much you should pull, how much you should left the graft before fixing the screw. Usually anything in between 3 to 4 millimeter. I usually left shorter.
What the literature was saying, if your tightening is too much, then the chances of ischemic changes in the graft are more.
Manish, since my tech person is here, we used to use Intrafix, and there was a tensioner in there, isn't it? There was a tensioner. You pull it to that amount of tension and then fix it.
Yes.
But
the best way is
to possibly
one should be able to, one should palpate the normal ACL and see how much of tension is there in the normal ACL. And that perspective has to be kept in the mind while you are putting in the graft and then tightening
In
it.
due course of time, you have laxity.
Yes.
So, if you're
So there is chances of
So I think what happens, situations are that when you put your screw, one bundle sometimes you see it's loosened up, and there lies the advantage of the other screw. You can just tighten those loosened bundle, and that happens when you are using a tighten screw. So sometimes you see there is a laxity in the one of the bundle of the suppose the 4 threaded or 5 folded graft, one of the fold is getting just loosened out. So in those cases, you just can tighten it with your after the partial fixation of the tighten with the adjustable loop. But again, too much tightening is not in the normal ACL. Sanjay therefore in normal ACL, a bit of laxity is there in normal ACL. And even after the ACL reconstruction, you can see you really look it. It's not that much of tightening what you have done during ACL reconstruction. So it's a stretchable graft.
the amount of tensioning which we are doing, cycling or we are tensioning it, is not really something on literature that this hour, and you will always see, you look, call the patient after 6 weeks, we normally do a bit of what more anterior draw than what you left on the table. You will always find, but gradually it decreases, and that is the amount of, you don't want the tibia and femur to be crushing each other.
So there was discussion about the fixed loop. Before a screw fixes. Once you have fixed the screw, everything is finished.
आपने दो पार्ट्स में जब ग्राफ से बनाया था 20 में और
या
20 में तो हम लोग को मिल गया था, फिर एक्स्ट्रा 5 में
एक्स्ट्रा 5 वही जो लैक्सिटी हो जाती है बहुत बार स्क्रू डालने के कारण, तो अगेन हम लोग उसको टाइट कर सकते हैं. एंड सॉफ्ट टिश्यू हैविंग टेंडेंसी टू गेट लैक्स विद द टाइम. 3 to 5 millimeter of laxity is documented in the literature when you are doing ACL reconstruction with hamstring tendon. So that is not with the BPTP, but with the hamstring tendon 3 to 5 mm of laxity will be there in the post-op period over the course of ligamentization of that tendon.
It's important कि जब तुम पूछे कि सर कब करते हैं उस टाइम में, बेसिकली जो हम लोग टेंशन करते हैं क्या उसका, this semi-tendinous and gracilis tendon is not made for a continuous all rest. It is a tendon. It is not a ligament. These two. So you have to get it out in the length completely, or if you leave it, it has a tendency to loosen up. हम लोग उस फाइबर को खींच के उसे कोलेजन को जहाँ तक हो सके लाइन करने की कोशिश करते हैं, पुल डाउन करते हैं, and that is the purpose that we give tensioning. कि वही बात कितना करते नहीं करते हैं. Because it is now fixed in femur, and before leaving the screw in the tibia or whatever fixation in the tibia, you give cycling.
so that whatever lengthening or the direction of fibers we are able to maintain, we get it down there at that time. अगर हम लोग टेंशनिंग बोर्ड पर लगा करके आधा घंटा जब तक टेंडर निकाल के उस पर लगा दिए और हम अपना टनल वाला काम कर रहे हैं उतना देर तक वो घुसा के पड़ा हुआ है 1.5 घंटा मैंने 30 मिनट पड़ा हुआ है फिर को उतना साइकिल करना होता है पहले नहीं करते बात नहीं हो रही
So basic tensor of the
cycling is only for mountains.
So basic tensor of the ACL is tight soliter, 2300 meter, and that ligament is not too much of tension, so that tension has to be created. So if you are using the fixed loop, suppose this was 40, and if you want that 10 mm of the lateral cortex to be still there, so this is the fixed loop. You cannot change this loop size. So if this would have been suppose 40 mm tunnel was there, and whatever the amount of graft you want to keep in the femur, suppose it's 20 mm. अच्छा, thank you very much. Thank you. Flight है, कल वहाँ पे उन लोग का academic workshop है. Thank you boss for taking the time. So if it would have been fixed loop, so if it would have been fixed loop, then suppose 10 mm of lateral cortex you want, so only 30 mm of that tunnel should be done with that the final reamer of the size of graft, that 30 mm. If you want to be 20 mm only, suppose your graft is shorter, then the loop should be that 20 mm plus 10 mm. So 30 mm loop.
फिक्स लूप जो आता है वो अलग-अलग लेंथ का होता है।
फिक्स लूप अलग-अलग का आता है। जो भी साइज आपका ग्राफ
फिक्स लूप का मतलब है कि एक फिक्स लूप है तो अलग-अलग साइज में आना ही पड़ेगा। टनल अलग-अलग होगा।
टनल अलग-अलग होगा तो
उसका मतलब ही बड़ा अलग-अलग। So right from 15, 20 पहले के ज़माने में 50 तक आता था, 55 तक आता था। अब तो आता है कि नहीं आता है कम। लेकिन 15, 20, 15।
So 10 mm of cortex आपको रखना है और डिपेंडिंग अपॉन द ग्राफ का साइज कितना है फिक्स लूप में आप उतना आपको ग्राफ के अंदर रखना है।
हाँ, फ्लिप लूप में कनेक्ट करने के बाद कि आप जब लूप डालिए तो उसमें जैसे एक ही पुलिंग थ्रेड है, उसमें दो लगा रहता है, दोनों काइंड ऑफ so one is pulling and one is clipping. Once you are out, then you just pull the other one and the एंडो बटन टर्न्स।
ये ऐसे है, ये एक इधर है। आजकल वेरिएबल लूप में भी काफी कंपनी आती है। ये एक इधर है और एक सिमिलर इधर रहेगा। तो एक बार आप इसको और एक बार इसको, तो टॉगलिंग आपको फील होएगी। जो भी आप फ्लिप कर रहे हो, वेदर इट्स इन द टनल और वेदर ओवर द फोन, तो वो टॉगलिंग आपको फील होता है। इट मींस यू आर आउटसाइड द टनल। So almost we have finished this. Any question related to this? And if it is not, then we can move to the simulator. अच्छा टाइम हो गया तो हम लोग लंच करके फिर सिमुलेटर पे आ जाएंगे। अभी नहीं बना। Then we can go to the simulator. Question है तो call upon the stage Dr. Manish Kumar from IGMS, Dr. Rikanju Mukhopadhyay from Delhi, and Dr. Sanjay is here. So Dr. Sanjay will join us later on. So talk with you. So there is some change in this schedule. Dr. Rajiv Raman has to attend some webinar. So we will present first. That is the meniscus repair inside out method. The video part.
Thank you, Theodore and Arjun, Gurudev, my dear friends, for invitation. So post-lunch session, I will be talking on inside out meniscus repair technique. If you see the history of meniscus repair, it's one of the oldest meniscus repair technique. The outside in and the inside out. And I think everyone should learn about this technique because all inside technique is not very cost effective. So whenever you want to do a cost-effective meniscus repair, either you can go for an outside or inside out technique. So just it's a video lecture session. So it's a 28-year-old football player. He gave the history of 10-week-old bucket hunter player. And you can see this is a classical locking knee, lock knee. This is the femoral condyle and this is the tibial condyle. And whole of your medial meniscus is in fact in between your femoral and tibial condyle. And what is locking? for posterior precedent, it's a entrapment of the meniscus in between the condyle. If it is between the lateral femur condyle and lateral tibial condyle, it's a lateral meniscus is locked. If you have entrapted in the medial femoral condyle and medial tibial condyle, your medial meniscus is locked. So this is a classical lock knee. So whenever you get such a operation with lock knee, the second important part is you want to reduce it under reason. Why? Because you have to repair it. So for repairing, the most important part is first to reduce it. And what is the maneuver? Normally, for medial meniscus repair, what we do, we put a valgus and external rotation force so that you have opening of the medial joint space. And once you have opening of the medial joint space, with your sixth finger, the arthroscopy surgeon call this probe as our sixth finger, you push your meniscus inside. And what is the technique of pushing this meniscus inside? And how you will retrieve this meniscus? So try to put this probe in the posterior most part and in the inferior part of the meniscus, so that gradually you will see with the click of the sound, whole of the meniscus will reside, come in between the femoral and tibial condyle. And as you can see in this video, you can see this is a lock knee. So my assistant is giving a valgus and external rotation force. You may go for a pica string also, and gradually I am pushing this probe in the under part of the meniscus. So try to push it, and you can see gradually the meniscus is getting reduced, and once you get a click and you see yes, and the meniscus is reduced. So once you reduce the meniscus, now you can start your repair job. Yes, you can do it all inside, you can do it with inside out technique, or you can do it with the outside in technique. The technique depends upon from which part you are approaching the meniscus. If you are approaching the meniscus through the joint, it's inside out. If you are approaching the meniscus toward the skin, it's outside in. And if you are doing whole of the suturing and the clamping or cinching of the meniscus within the joint, it's all inside meniscus finger. So I will be talking about the inside out technique. And these are the two very important instruments. First thing is your double arm needle. You can see there are two sharp needles there with an fiber wire. Normally it's 205 wire, which is used for the meniscus repair. And you have different cannulated system for passing of this needle. Normally you have 20 degree up system, 20 degree right, 20 degree left, and one is 20 degree down system, so that you can reach in every part of the meniscus, the posterior horn, the body, and the anterior horn. So this cannulated device and the double arm needle are the two instruments which we use for the outside in technique, inside out technique. So once you have reduced the meniscus, now try to start your repair from the posterior horn, and this is the standard dictum we follow in fresh meniscus tear. Except for the very old meniscus tear, sometimes we try to put your central stitch first, so that whole of your meniscus is centralized. Then you put your posterior stitch, and then you come to the anterior most stitch. So in this case, you can see here, this is your double arm barrel, and through this double arm barrel, we are trying to put the needle, we are trying to cross the needle in the posterior horn. You can see. And once you cross it in the posterior part, you can put a small nick in the posterior part, and you can see once you pull it, the whole of the meniscus is getting cinched with the capsular tissue. This is very important part. So once you have put your first bite, now you start taking the second bite. You can see here. Then again you can see this is the double arm barrel. You put it in the horizontal manner, it will produce a horizontal mactus suture. If you put it in the vertical manner, it will produce a vertical mactus suture. Now the question is that whether you will go for a horizontal mactus suture or vertical mactus suture. Always try to give a vertical mactus suture, it will have a more cinching effect. But whenever you want to use less number of suture, you can come out with the horizontal mactus suture also. So standard suture of choice is vertical mactus, but here we are putting horizontal mactus suture because by 3 suture only we can reduce whole of the meniscus. And this is the second device, second suture we are passing. So once you have passed this meniscus, you can see. Now I am putting a vertical mactus. Just I am putting the barrel in the vertical, this direction, and my two needles will cross like this. You can see, and now it will be a vertical mactus suture. So you have a suture in the posterior horn, in the body, and in the anterior horn, and all these three sutures will ultimately, you can see here. So once you have repaired it, this is very important, you should see for the stability of the repair. Normally what happens, whenever you repair this meniscus by the inside out technique, this is your meniscal tissue, suppose 2 layers of the meniscus. So you are causing a cinching between the capsular layer and the meniscal tissue towards the knee joint. So once the cinching is there, if you try to probe this meniscus out, because you have put a knot on the outer side, the capsular tissue will not come in. So here you can see, so once you have Now again you give a valgus rectal rotation and you can see whole of the meniscus has cinched very well with your capsular tissue. So normally when we go for a bucket angle repair either for medial or lateral meniscus, our standard protocol is keep them for non-weight bearing for 6 to 8 weeks, again partial weight bearing for another 4 weeks, and you can allow them knee movement with weight bearing on vessel, because we don't want any rotational movement, any pivoting inside the knee. So try to keep them on their knee braces for 4 to 6 weeks, be guarded in rehabilitation, and try to get 90-degree beyond movement after 3 weeks. Normally in ACL, normally we try to get 90 degrees of movement by 7 days. But here, if you are going to meniscus repair, try to put the greater than 90 degrees of movement after 2 or 3 weeks, so that you have less standing effect of over the meniscal repair tissue between the femoral and the tibial contact. And now I will show what is cinching of the meniscus repair. You can see this is the inside of meniscal repair. You can see this is the horizontal mattress suture. So once you pull inside, you can see here the whole of the meniscus is getting attached with the capsular tissue, and that will produce a fibrous healing at the meniscocapsular tear junction. The junction at the meniscocapsular tear has occurred. So inside out technique is a very cost effective technique. You just need either a proline or double arm stitching needle with a suture which costs hardly for 2,000 for a bucket headed tear. With 6,000 rupees only you can repair whole of the bucket headed tear with the inside out technique. The important point is that avoid using inside out technique for the lateral meniscus. As we discussed, we don't go for a usually we avoid doing a lateral meniscus repair with the inside out technique because of the position of the common perineal nerve. So most of the time, either you want to do a pie crusting or you want to do inside out technique is for the medial meniscus. Don't go for the inside out technique for the lateral meniscus, because in the posterior quadrant there is a high risk of damage of the neurovascular tissue. Either you didn't go through the popliteal artery also, or sometimes you may touch the common perineal nerve also, so that patient will have common perineal nerve palsy. So avoid using this inside out technique for the lateral meniscus root here. Thank you. Yeah. So lateral side, I don't use inside out technique. For medial side, if you are using, because what happens when you are putting your needle is crossing on the posterior medial quadrant, usually they cause entrapment of the nerve, superficial penis nerve there, and that causes the neuroma formation also. So make a vertical safety incision in the posterior medial part and try to take all your suture out of the posterior medial part.
Very nice demonstration. Any questions from the house?
So this inside out technique is well known for medial side, but you can do for the lateral side also if there is possible the problem for putting or inside suture angle. So for that you have to put the safety incision, and there is cannula to direct your needle not going posterior, either on the lateral side or more anterolateral side. So for using inside or technique on the lateral side, you use that safety incision as well as the cannula.
But big process, because you are doing whole of your work in the figure of floor position. So orientation should be very good. Otherwise, your orientation should be very good for using inside out technique.
One question. As shown on the video, there was a very nice reduction of the meniscus. Oh, what is the time frame or the time limit where the reduction becomes very difficult, or you should not try to reduce it?
Very good question, Malik. So normally, when the meniscus is unreduced or is there, you have not repaired it for a long time, there is a term called synovalization of the meniscus. And what are the characteristics of synovalization of the meniscus? The most important part is rounding of the medial border. You can see even after 10 weeks in this video, you can see there was no rounding. The medial border was, you can see it's a sharp medial border. This is one of the indications where you can think, yes, I will go for a meniscus repair. Second thing is irreducible meniscus. What happens? Whole of the meniscus tissue gets swollen up because of the synovial fluid infusion, and you cannot reduce this meniscus. For me, indication for meniscus repair is up to 12 weeks. There should be no synovalization of the meniscus, there should be no rounding of the medial border, and the meniscus should have a proper shape. It has not rounded.
That means up to 12 weeks, you try to actually
All the
reduce it.
So time is important. What is important? Say age, quality of the meniscal tissue, and time. So you should have a combination of all these criteria in decision making. So suppose in 10 minutes I put my scope inside and see the whole of the medial body is rounded. It's a complex tear. You can't reduce this meniscus. It's like cord-like meniscus is there. At that time, better to go for a balancing than repair.
Nice. Anything else? Any other questions? Okay. Thank you, Dr. Raji.
Thank you.
I will call the next speaker. It is Dr. Kumar Gaurav. Suppose we will be speaking on the decision making meniscal tear. Hello. The topic is meniscus surgery decision making. And I want to tell you what is the importance of this topic. Meniscus is the most common intra-articular knee injury development. Even in our country also, but it is not as frequently diagnosed as other countries also. Most frequent cause is surgical procedure performed by orthopedic surgeons and annual incidence is 0.066%. So, meniscus surgery is a surgery which we are going to do in maximum number of cases in future. So, everyone should be oriented about it. What is how the meniscus is important? Meniscus has to distribute forces between tibial and articular cartilage with a load sharing action. Distribute the stress across the bone during the shock of the and secondly joint stabilization. This is the importance of meniscus. So what goal of meniscus surgery is to reduce pain and disability, to preserve the meniscal function, to avoid additional cartilage damage, and to restore activity to pre-injury level. So the decision of surgery depends upon precise knowledge of meniscal shape and function, types of injury, surgical techniques, post-operative rehabilitation care, and patient post-mortality compliance. So the knowledge of meniscal shape and function is important. As we will discuss about surgical techniques is beyond the scope of this paper. There are so many doctors discussing about this post-operative rehabilitation in meniscal rehabilitation takes 3 to 6 months to heal properly. So the patient and the post-operative compliance, this is important. The patient should be oriented about it. Option surgery is to either save the meniscus or shape the meniscus. So, history of meniscus surgery. Historically, meniscus was considered a vestigial pregnancy, but commonly resected. So, in 1885, American was performed first open meniscus surgery, and 1948, here was registered that meniscus surgery is exposure to arterial degeneration. From the day onward, we started to save our meniscus to repair it. In 2013, a review found that number of meniscus repairs performed was double in last 5 years. So the number of meniscus surgery is growing day by day. Now, you should know about meniscus blood supply. Blood supply is very important, but whole meniscus is respired. At the second year, area is blood supply. In 20th year, when the people become almost adult, then peripheral third is respired, and when you grow old, 50 years, peripheral quarter is respired. So, this is the blood supply from that in the see the blood supply from lateral, medial, and medial chain fillet artery penetrates the joint capsule from the perimeniscal plexus, and the radial branches penetrate from the meniscal fillet for 2 to 3 mm. So most consistent blood supply is at the rear and posterior horn, and completely venous from the lateral meniscus has worse supply. So the portion where this blood supply is best, you can the results of repair will be the best. Simple fundamental thing is that one. So peripheral areas and all these things where the supply is good, you can repair it as you like. So there is good classification of zone distribution. This is the radial zone A, B, C, D, E, F. That they have distributed it according to the blood supply. So that you can classify your meniscus and accordingly repair. Zone of vascularity is that red, white, and white. Red zone is peripheral line is fully vascularized, a very good potential of it. But white matters, the inner third is avascular, less chance of it, and the middle third is red white, middle third partially vascular. You can plus minus surgical options and your judgment. So what is the important question? It's good evidence is good, but this is important. We have seen. Answer is no. As the doctor told that even in breast and I think only 20% can be done. The rest you have to say. Meniscus repair you have. So is in every case is nicely seen. What to do? There are many options for medical surgery. Either you neglected meniscus surgery or meniscus surgery. There are other options also for meniscus transplant and replacement, but we are not acquainted with these things. We do not discuss much about it. Surgical intervention, in which cases surgical intervention is not required. This is important. That is, here is there no surgical steroid or peripheral located vertical intervention. Here has already told that better chances of it. In incomplete longitudinal tears, small tears, tears and posterior horn of lateral meniscus can manage relatively well. So, meniscus repair. Repair has got added advantage of meniscus repair. First, it restored function, repair load transporter, minimize contact distances, contribute to stability and control protection, scattering protection. So, meniscus repair should always be tried if you can, and if it is feasible. Meniscus repair is the best option. So, when to do it in acute tears means less than 3 months ago, you can consider. Peripheral tears, because the blood supply is good. Unstable tears, tear length is more than half meniscus or let's say unstable tears should be repaired. And young person, possibly less than 20 years, unstable knee profile, these are the conditions for meniscus repair is better. When to avoid only complex tear has poor healing, degenerated tear, and unstable means without infestation. Unstable should not never be necessary. Should be repaired unstable. If it was going to stabilize only, ISL reconstruction or other then only you can use meniscus repair. So there is single handedly in unstable teeth that time. Grade 2 osteoporosis means cartilage damage to a great extent. It does not have any meaning because patient will be painful. Maybe some other meniscus will try to repair it. And older because older degenerative tear has tried to most potential of recurrence. Old age is not very advisable. Here the time the potential recurrence is long. This is a basic concept. Old age is concept or later there is longitudinal or later these 3 tears are only repairable and has good reasons. Even the other tears people are trying and nowadays we are going to try these tears. This is the option depending upon your physical skill and choices as well as this is it. So there is this is a diagram, this is a chart where you can draw data that the rotation is high tissue quality from Nigeria data. This is a one system of marking, the vertical system is to calculate all the system and calculate all the point. If it is less than or equal to this, then meniscus repair has a good. This is is not demarcation line. Even if you can go beyond this line, that's fine. As such, there is have good results. So there are techniques of repair that we discussed coming to the outside, such as inside out, etc. These are the indication which what type of repair. So we will discuss in subsequent very large just single chart. Overall conditions of repair can go for patient factor is younger, active individual, 30 years, no significant comorbidities, BMI simply less than 5, and willingness to comply with those longer post-operation longer. And the clear characteristic related and identified by the zone is negative. Less than 3 months associated with ACL reconstruction. Reducible without ACL and lower threshold for complete fertility. So all these things are not dependent on section or
thank you, Dr. for the answer. So we have questions on what are the indications and when a minister should be repaired or when it should not be repaired. So if there is no question, I would like to ask, when you say you would not do a menstrual repair on old patients, so I would presume 40 years you're taking as the landmark age. So in a patient who is more than 50, would you even consider a meniscectomy or you will just leave that patient conservative?
most of the time in old age, I conservative control. You only hope that go for surgery when conservative treatment does not get good results. Patients constantly complaining of this thing, and because most of the time beyond 50 you get complex tears. It's not simple that that I fell down or necessary. Old age is not good. So I don't prefer it.
So that is one point I would like to elaborate on for the delegates. In the elderly, you may come across a lot of patients who come with an MRI and tell you that they have menstrual care. And as a young upcoming arthroscopic surgeon, you may be tempted to take up those cases, but more often than not, you will actually burn your fingers with the patient, returning to you with worsening of pain. So these patients, more than 50 degenerative tears, actually don't do well even with a meniscectomy. So keep them conservative, tell them the prognosis and wait out until it's time for a TPR.
So in elderly people, all the meniscus should be managed conservatively. There is only one indication for meniscal surgery, that is locking, and it is because of trauma. If patient is having traumatic meniscal lesion with locking of the knee joint, patient can't able to fully extend or can't able to fully flex, that is the only indication in case of elderly population for meniscal surgery, and rest meniscus should be managed conservatively. One condition that meniscal tear is associated with ligamentous injury. Another condition, there is isolated meniscus tear is there. There is no any ligamentous injury associated with that. So which meniscus will repair, which meniscus will say it should be managed?
Both meniscus should be repaired. Both meniscus should be repaired. If the ligamentous laxity is repair the ligament or reconstruct ligament, whatever you are doing, make the meniscus and repair the meniscus. This is good indication for the meniscus. ACL, for example, ACL injury, meniscus requires good education and the stability of knee, and they are going to make coming step always require meniscus if possible, if it is repairable. Even isolated, when the meniscus injury is isolated, then it depends upon how the it can be repaired. As you told that if patient to file exam, it is not repaired, and if you can repair the meniscus, meniscus should always be repaired. If you can repair the meniscus, and if you think that meniscus is repairable, it should always be repaired.
So, if it is ligamentous injury, it's very easy to repair the meniscus because your knee is lax. You will have a space to work over the posterior part of your knee joint or on the lateral or medial side. At the same time, with ACL reconstruction, you will have lot of floor factor because of tunnel removal. That help in repair of your meniscus. In isolated meniscus tear, your knee is stable, it's not unstable. So you have to do something like tie crusting and other thing. At the same time, after repairing of meniscus, you have to enhance the biology of your knee in form of doing microfracture in the intercondyle area, so that your knee will have lot of growth factor inside the joint, and that help in repair of meniscus. So in ligamentous injury, always try to repair because chances of bridging is also very high. In isolated meniscus tear, if you have difficulty that if there is chance you can damage the cartilage while doing repair, so you can come with the meniscectomy.
Mr. Boacon, as we go with the anatomy of the menisci, you see the lateral meniscus is more mobile than the medial one. It has got many deficiencies in its attachment to the capsule. So what precautions should be taken when you are going for a repair of lateral meniscus pertaining to its not attached areas like the pocket to hiatus area? So what precautions do you need to take? Very less lateral meniscus is less blood supply. It is up to 25%, while to 30% in medial meniscus. So lateral meniscus repair are not as good as medial meniscus. The precaution while repairing the lateral meniscus is that it is mobile, and already Dr. Rajan told that we are doing most normally we are a position when we are doing for inside out or outside. So anatomical orientation is more important. Once we are doing all inside orientation, it is relatively safer and easier to do for lateral meniscus. You can go for engineering, but results not as good as medial meniscus. This is the decision making. You have to utilize you have to properly decide that whether I have to manage this meniscus and whether to dissecting or repair. Then you think about it.
Thank you, Dr. There are no more questions, so I would like to call on the next speaker, Dr. Rakesh Chaudhary, and he will be speaking upon the technique of meniscal demonstration.
Right, good afternoon. I will be talking about all insights. So nothing here and there, nothing about indications and etc. etc. Straight away, one slide each on one slide each on just indications and other things. All insight technique is not new technique. It has been there over years. I will go to that. But it is a relatively very, I hope I will see, costly, but a relatively easier and fast solution. And that's why it is really picking up. And as gradually the instrumentation of this all inside technique is getting better and better, the technique is getting easier, and the amount of time, but the cost increases. So it is important. All of us have already seen that helps in load dispersion,
loads absorption, proprioception, rotational and translational speed. We all know that this is there. First all inside repair documented in literature was performed in 1991 when Morgan used a curved suture hook to pass the suture across the tear via this portal, and the repair was done. While partial meniscectomy continues to play a role in specific tear pattern, its indications are progressively decreasing, getting limited with the more we go into various undocumented areas, different networks we have not gone through, and the indication of meniscectomy is getting limited. I won't say it will go up at any time, and the meniscus should be preserved whenever possible. It is when I would have talked to about what we do with meniscus, then we would have talked. Meniscal repair results in significantly better outcomes than partial meniscectomy in terms of returning to pre-surgical activity level, slowing rate of osteoarthritis, and restoring range of movement similar to an injured knee. So it is important. But the advantage of all-inside technique is all-inside can restore tissue continuity without fixing the meniscus to the surrounding tissue. As you do inside out or outside in. You take the threads out and then you tie it outside. So you have fixed that meniscus to a lot of extra articular tissues. So now the movement is lifted. But if you do with the all-inside technique, the limited, there are various techniques which make it better. All-inside technique restores knee contact area close to its native. All-inside technique also avoids hyperstability, which I already said, because if you fix the lateral meniscus, which is mobile to the capsule, it gets fixed to it, and chances of re-tear increases if we mobilize the patient early. But all these observations have been made in biomechanical study, so I don't know about the clinical outcomes. So, further it avoids documented risk associated with inside-out repair, including lateral genicular artery observation with extra-articular knots and nerve injury, which I already told. If you tie it from outside, you can damage various nerves. And lastly, all inside repairs have been shown to have reduced operative time and faster post-operative recovery time. Thus, there are still unanswered questions. There looks a sufficient early evidence that all inside technique can utilize a variety of configuration, including radial, vertical, horizontal tears. Today I am showing you two small videos about radial and horizontal tears. We are now using 4th generation of all inside instrumentation, which all sutures are allowed tensioning. Important thing, which just now we are talking about, what you do lateral. It can now have been done by two methods. One is the capsule based, capsule based and meniscus based. In capsule based, we put the dart which goes into the capsule and fix it into the capsule, meniscus to the capsule, and helps in getting blood supply because we have roughened it up. But the other one is meniscus based. The whole system is in the meniscus itself, so it is not fixed to the periphery. So the mobility of the meniscus is still there. So all-inside technique has a self-adjusting with the anchor located behind the capsule with sliding knot, and that can be tensioned. So I will like to give you a small light and get the video please. A very small demonstration, just it can be a waste of time, but look at it, what we do. I will give you what we do in the knee. I am grateful to these ASEC people who gave me a new dart, otherwise they never spent this 15,000 thing on a demo thing. So it is a new thing. So this is the, hopefully you are seeing it very clearly. This is the tibia and the meniscus here. Everybody happy with this? So this is the meniscus. It is not down here, but believe that it is torn at some point. So look, probe, always before repeating, it should be reducible. make sure the meniscus is reducible to its pairing position at native position. If it is not, there will be a lot of stress on the fiber and it will break, certainly break. Okay? So, it is just one system. It can be of any number of things. So, हम 5 मिनट टाइम देंगे। हम So, if you are happy with the now, then I have to tell question. So, this is the instrumentation through which we do. There are preloaded everything in there. The dart, the thread, the knot is all built in there. So, if you look, this metal thing has got few marks, which is the measurement. So it has got few marks in the metal, which is the measurement. So what we do, we go in, say at any position, and we know that this is the depth where the meniscus ends. So we should not go beyond this. That is for sure. So what we do is get this thing going forward. So now my whatever I push, it will will not go beyond this point now. One thing very clear. So now whatever I push, it will stop at this white point. So I am happy with this. Now meniscus reduced. So we go at one point into the meniscus. So it is there. If you can see the metal out in the so one dart has deployed. If you can see there. Now I get back. Can you see the dart there? One dart is deployed there. Now we go to the second. Again it is out. Second dart deployed. Now we come out and go ठीक है अगेन इसके अंदर देखना है सो वट एवर एवरी सिस्टम हैज इट्स ओन मैकेनिज्म and then we just pull this anyway निकल गया is not meniscus hardly it just goes and it gets tight there so it just fixated और ये निकल गया यहाँ पर बड़ी अगर यहाँ आता तो वो हो जाएगा इसको फिर से बाहर पकड़ने
पुल करोगे तो आप उसके ऊपर बैठ
उस पर आकर के बैठ जाएगा सो दो थ्रेड से दो डार्ट उधर हुआ दो थ्रेड उस पर आ गया थ्रेड और वो उसको दाब दिया सो वी आर एट अ position. So this is the basic principle on which we work. And you can see it is a quite peripheral tear. Fresh tear. Happy with it? So you freshen the edges, whatever is there. Before that, you should be able to reduce it, but it was done. So then you abrade the peripheral part so that it becomes rough, refreshing, bleeding, fresh bleeding. You are in a tunicate, but if you open the tunicate, bleeding would from there would happen. We reduce it. And then this is a jig through which we go the dart which is there. So we go in. Go in. Pass on one dart there. It is a multi-loaded dart. I already use this. It is multi-loaded. So you go back again. Similarly, deploy. So you can, normally what you get is that only with 2 darts and you finish it and then take another instrumentation. And you tighten it up. And you cut the suture. You will see how it tightens to the periphery. As well.
Previous suture was the horizontal mattress suture. This is the vertical mattress suture. So that suturing thing was discussed by Dr. Rathi.
And so with it, happy, good. And you can see what Raman was saying that it will become. Just a 20-minute video of a horizontal tear. You again refreshen it. And basically you do the same thing, one up and one down, and then you tie it. So we do it at button point. Good. Thank you very much. Sorry for that.
Thank you, Dr. Rakesh, for the wonderful demonstration as well as the video. I'll just add one point here. Whenever you're repairing a meniscus, always try to balance the tension of the sutures on the femoral surface as well on the tibial side. If you don't balance and you put all your sutures on one surface, you're going to lose out the normal flanks of the menisci. So always try and alternate one up, one down, one up, one down.
Just give you very basic. That's why I didn't go into those technicalities. Anything you want to ask?
Hello? Sir? Sir, how can you calculate the depth of the meniscus? As you shown in the graph, how do you calculate that meniscus, whether you have to put it on 18 or 16 or 22? How do you decide this?
What you measure is from here. एक मिनट तो मुझे ठीक है सर ठीक है सर मैंने सबका अलग अलग है मैंने हम सबके लिए दिखला देते हैं ये इतना लंबा इतना चौड़ा मेनिस्कस नहीं होता एक बात बहुत क्लियर है और जब हम गए हैं इसको ये टिप पर चलेगा
जैसे इसको एडजस्ट करते हैं सर हाँ इतना चौड़ा मेनिस्कस सबका तो अलग अलग है
अरे हर एक अलग अलग करेंगे
See, this is the Gaurav.
जितना भी रहेगा
Gaurav, this is got up. This is the
Marking क्या है?
Marking over the needle.
हमको इसमें 12 mm का मिला और उसका 18।
Dr. Rakesh, what is
This is
asking
the
is how
marking
do
over the
you
needle.
decide the depth?
You go inside the joint and place this needle over superior surface of the meniscus and check outer diameter and inner diameter, outer margin and inner margin. So suppose outer margin and inner margin, you see the marking is 12. So this is the depth.
इसमें 1 है, वहाँ तक ले जाकर 1 को पुश करो। अब उसे क्या हो जाएगा?
Yeah, there is probe also and here middle marking is up. You can see it's the 12. Here it's 12, here it's 16. So this is how you measure the time.
What is the distance difference between the two rods?
Between two anchor. Yeah. So it depends on
1 सेंटीमीटर हम मान के चलते हैं, बाकी कितना पैसा देता है बहुत इंपॉर्टेंट है, कितना बड़ा चाहिए है, कितना पैसा पेशेंट खर्चा कर सकता है 1 सेंटीमीटर।
So it's maybe vertical one or it's maybe horizontal one. So vertical one don't have any problem. One in the capsule, one in the substance of meniscus. If it is horizontal one, ideal ligament length is 4 mm. 4 mm apart and at the interval of again 4 mm gap. So rule of 4 for the meniscus repair. Less than 40 year of age, less than 4 months maximum. It should not be more than 4 months. 4 millimeter gap. Your needle should be 2, anchor should be at 4 millimeter again. After repairing the meniscus, at least 4 microfracture in the intercondylar area. That will give you the PRP, bone marrow, everything. At least 4 weeks of non-weight bearing and 4 months of avoiding any sports activity. So rule of 4 for meniscus.
जितना बड़ा हर एक पॉइंट पे तुमको 2 लगेगा। अगर ये 4 का है तो तुमको 4 पर लगाना पड़ेगा। हम 1 का है कोई बात नहीं, इसके क्वेश्चन थोड़ा सा डिफरेंस है। पर वी आर टॉकिंग अबाउट द आइडियल कंडीशन, बट हम नहीं लगा पाते हैं क्योंकि उतना पैसा इसका एक का दाना 14,000। अगर हम अगर 10 तो लगा दें तो इसका तो बिल बनेगा, मेरा तो टैंक खोल के ले जाएगा।
So you have to balance how unstable it is, how much you need to repair, how much you need to reset, how your patient is affording. All these you have to balance. So many a time you can take maximum part of the meniscus, the root part or posterior half. That is the most important thing. You can preserve by putting 1 or 2 things. If it is complete from there and there, then you have to follow the same rules. Nowadays, with the help of mini scorpion or first pass mini meniscus scorpion, you can just take simple thread and you can put a circumferential stitch over the horizontal without any cost. In fact, if you want 0 or 2 number 2.
Okay, thank you, Dr. Rakesh, a very nice presentation. I would like to call upon the next speaker is Dr. Tarun Solanki. He will be speaking upon the meniscus root repair.
Hello, good afternoon everyone. Thank you organizers, especially Dr. Arvind, for giving me the opportunity at Boacon, Hajipur 2022. So basically root tears are basically defined as radial tears within 1 centimeter from the meniscal attachment. They can be either soft tissue or bony. If we come to the etiology or the associated injuries, lateral meniscus, posterior horn, they are generally associated with the ACL tears. You can say with 10% of ACL tears, posterior horn, lateral meniscus can be seen. Anterior horn, less common, mainly iatrogenic, while having non-anatomical ACL tibial tunnel remain. Medial meniscus, posterior horn, they are mainly degenerative and they represent 21% of the posterior horn medial meniscus tears. And the anterior horn, again, iatrogenic when there is rimming for the tibial shaft nailing. Coming to the anatomy part, they are basically landmarks can be taken from the lateral tibial eminence and the medial tibial eminence and from the most proximal attachment of the PCL of the tibia. And as you can see in the first and the second slide, And for the anterior horns, again the landmarks are the medial tibial eminence and the lateral tibial eminence, and accordingly they can be seen. Coming to the biomechanics, the basic role of menisci is to convert the axial femoral loads into the hook stress. So whenever there is loss of meniscal anchoring, there is abnormal distribution of knee loading, which causes a decreased tibial-femoral contact area and the increase in the T contact pressure, which can be up to 25%. Coming to the lateral posterior root, it acts as a primary stabilizer for internal flexion and high flexion angles. So whenever in ACL we have grade 3 Leishman or a 3+ pivoting, we should always think of having a root here of the posterior horn of lateral meniscus. So a repair of LPRTs concurrently with ACL is recommended to avoid persistent instability and increase forces on the ACL graft. Coming to the diagnosis part, the basic locking and the catching giving way signs are absent with the root tears, which we generally found in the menisci. The main indication, main signs are pain with full knee flexion, joint line tenderness, and the positive MAC malaise. MPRA, which is the least mobile, so the highest incidence of tears. Coming to the imaging, MRI is the modality of choice. They are basically in 3 sections. We can see in the axial one, there is a linear intensity at the root area. In the coronal one, there is a vertical intensity, and the more important is the exclusion sign. When the mid-coronal images, there is exclusion of more than 3 mm, we should always think of a root tear. And in the sagittal one, there is a ghost sign with the absence of normal meniscus signal is seen. Classification, Fred et al. Given 2015, basically type 5. One is a type 1, which is an incomplete. Type 2 is a complete, which can be further divided into 2A, 2B, and 2C, depending upon the distance. Type C is a bucket handle with root tear. Type 4 is a complex tear with the root, and 5th one is the boniable. So coming to the treatment part, a elderly patient who has grade 4 osteoarthritic changes, which can 4, they can be analgesics, activity modification, and unload a brace. For meniscectomy, only the degenerative ones with persistent mechanical symptoms. If the patient is having locking episodes despite having degenerative changes, we can go with the meniscectomy. Root repair is the most commonly done thing for the meniscus root. There are 2 methods, a suture enter repair or a transtibial pull-out repair. We generally follow the second one, transtibial pull-out. Suture enter repair is basically more demanding. If you have a high posteromedial portal through which it can be done. Transtibial pull-out repair can be a single tunnel or a double tunnel. The recommended one is double tunnel with 2 stitches. This is basically instrumentation. There are these special root jigs, but you can use the ACL jig also. The difference in this root jig is only the curvature to accommodate the eminence. This is a small video, courtesy Smith and Nephew animated before the original one. So as you can see, the root bed is being prepared, and this is the basically jig showing the curvature, as I told you, to accommodate for the eminence. This we have passed the guide wire, rimming done above it. And the bite can be taken, the easiest way to have is a mini first pass. This way we can have a bite. Ideally 2 bites are recommended. And these can be tied over the endo button. Sometimes a osseous bridge can be used, but with time abrasions can occur and it can lead to loosening. This is a patient, Jyoti, 23 years. Whole of the lateral meniscus was in the joint. Among the root tear, there was also a body eversion, and in the coronal, you can sagittal and the ghost sign. This we did for the root repair. Basically, a bite has been taken in the root and jig used, pin passed, and then the bite taken out and then railroaded through the tunnel. And then it is being fixed on the surface. This is just to show a post-op X-ray. In this, the patient was having too much problems Just the encircle one is the root repair endo button. Another patient having ACL with the root pier. And for the post-op rehab, there should be non-weight training for 6 weeks. You can have a passive range of motion on the post-op day 1. And deep leg presses and squats with greater than 70 degrees, that should be avoided for at least 4 months following surgery. Thank you.
Last demonstration, Dr. Solanki. Any questions from the house?
So what are the age group where you find this root avulsion lesion? Other than multiligament. Multiligament having this avulsion part very common. But other than that, what are the age group where you
Less than 40 years. The lateral meniscus posterior horn, generally might be traumatic one. And the medial meniscus posterior horn are mainly degenerative in fatty females with varus malalignment, which we don't recommend to go for the repair one.
So it's the age group in between 40 to 60. Patient having one day sudden popping sensation inside the knee joint, and after that she don't have any relief even after visiting 4 or 5 orthopedic surgeons. She is taking analgesics day, night, morning, but whenever she start putting weight over the knee, she is having pain. This is very classical history of root avulsion in this age group. It's also very common with the multi-leg, but other than that, in middle-aged female, this history is very common. And these type of patients keep changing orthopedic surgeon because there is no pain relief. All the time she start walking, she is having pain. It's very characteristically on the posteromedial side, and if you get X-ray done, along with all these classical signs of this MRI ghost sign, truncation, extrusion of the meniscus, you will see there is lot of bone marrow edema inside the posteromedial side of the tibia. That is also very common.
Very classical finding on MRI.
Yeah. Okay. So depending upon whether it's what is the condition of the cartilage and other part inside the knee joint, if cartilage is fine, there is no any malalignment, you can go direct for the repair. But in case if there is varus malalignment is there, or cartilage is little bit degenerated, but patient knee is having life, only 50 years or something like that. So you can add osteotomy in that, you correct the varus part by doing high tibial osteotomy and the repair at the same time.
The alignment has to be corrected along with it.
Right. You see, the root repair surgery is a very meticulous surgery, and success depends upon how meticulously you perform the procedure. Now, there are certain, if you don't have a good bite in the root part, so do you have any tips and tricks to have a very good bite in the root so that there is no chances or less chances of...
I think in older cases there are certain adhesions, so you need to clear the adhesion first so that the root can be pulled up and you can have at least 2 bites if you are able to have, so that a good footprint coverage is there, and so it's a good biological medium.
If you want to are able to get a bite, slightly not that's so good part is called the pathology was very near to may good signal problems. Just in case if you fail, you are putting meniscectomy and tears, then only.
So about the white part, it should be just inside to the meniscocapsular junction. That's the tissue that is the most important and most strong tissue there. Your bite should be there only. Otherwise, very high chances of repair. At the same time, tape is having added advantage over the suture.
So the chance of cut through is very high.
The chances of cut through with the suture is high. So always try to use tape in place of this suture. And cinching of that tape is again preventive in re-tear. If only there is circumferential thing is there, the chances of tear is high, as supported by literature. If you do the cinching thing, again chances of re-tear is this.
Okay. I think the session ends here, and Samsul,
Thank you, sir. Thank you, everybody, for a wonderful session. I request the course Director Dr. Alamta, please come to the dais. We have to felicitate 2 more faculties.
Dr. Kumar Gora, please, on the guy, and Dr. Manish and Dr. Ritaju Mukhopadhyay, kindly facilitate Dr. Kumar Gora. Memento, please. Dr. Rakesh Chaudhary, sir, please come on the dais, and Dr. Manish Kumar, kindly facilitate. And lastly, Dr. Samsul Hoda, who is looking all these thing facility available to us. And Dr. Razim Anand also please on the desk, along with Dr. Manish and Dr. Ritaju Mukhopadhyay. So thank you again for such a wonderful session. Now we'll move to the, since workshop on the meniscus has already covered by Rakesh boss, so he did my job half done. So do you want again workshop on meniscus, or you people want to move on the simulator part? Simulator? That's perfect. So please come over. One table will be guided by Dr. Rajiv Raman and Dr. Manish. Another table, Dr. Ritaju Mukhopadhyay, me and Dr. Tarun Solanki.
Inside the knee, you are inside the knee. So inside the knee, again, first, like the focus is like this. You are inside the knee. So see,
ऊपर है तो आप नीचे देखो.
this is a medial compartment. Now you see, you are in the medial compartment. In between the medial femur bone and you can see the medial meniscus. See the medial meniscus. The smaller part is tibial condyle, femur condyle, and medial meniscus. So medial meniscus has three parts. Alright. So first you want to see root. Root is the posterior part. So rotate like this. You can see this. This is your root. Then you want to see the body. This is your body. Then you want to see the anterior. This is your anterior. So it's like that. 90 degree body. Body. Come back. इसको डाउन करोगे तो now you are the intercondylar. You have medial femur condyle, lateral medial femur condyle and lateral femur condyle. Lateral femur condyle. This is the third ACL. Medial femur condyle, ACL, lateral femur condyle, ACL. If you want to see the TCL, you have to go towards the medial side. So you move it like this. If you want to see the ACL, you have to go like this. Then lateral meniscus. Best way to see the lateral meniscus. Lateral meniscus में you want to see the disc coupling.
देखो क्या है यूजुअली
This position normally you
प्रोब भी यही
can start with the root.
नॉर्मल टेंडेंसी ये इधर फिर आप ढूंढते रहो तो इधर है तो ये भी इधर ही जाए आपको दोनों लाइट
This is the best way. You have good control on this. Then you come inside the intercondylar. Which one is medial condyle? This one. You want to see medial condyle. You will rotate like this. Medial femur condyle.
That is the network for orthoplasty, but once the decision has been made to proceed with orthoplasty, several controversial issues need to be considered like type of orthoplasty, hemi or total, if hemi replacement, then unipolar or bipolar. Unipolar is outdated now. The indications are very well there in Campbell that more than 80 years, housebound ambulation, patient is expected to die within 2 years, then you should do the Austin move. When I joined Banaras University in 1987, even in that medical college, at the age of 50, Austin move was being used. But now it is no more, it is 80, that's it. So you should go for a bipolar. Now which bipolar and why? Which surgical approach? Here, whatever talks I have listened, we are all very much used to the posterior surgical approach, that is how we have been trained. But you should remember that there is a very high incidence of posterior dislocation with the 4 to 5% with the posterior approach. Lateral harding approach is another option, even for total hip, that gives a very good exposure to the scapulum and gives you a very good idea about the versions as well. Now, this is a paper by Romesh Bhandari in the United States, and this is published in New England Journal of Medicine, total hip arthroplasty or hemi-arthroplasty for hip fracture. Obviously, he has proved in this paper by studying in 10 countries that there is hardly any difference in the outcome if you go by hemi-arthroplasty like bipolar or a total hip. However, the cause, blood loss, infection and technique are much more advanced for total hip. So you can very well get away with the hemi-arthroplasty. Now the question is which type of hemi-arthroplasty? The theoretical advantage of a bipolar process is combined torque of motion of the dual joint should reduce the incidence of dislocation. There is significantly higher incidence of stapler erosion in the unipolar group, may imply that bipolar should be preferred treatment. Unipolar arthroplasty versus bipolar arthroplasty. And works like unipolar in 2 to 3 years time. Many where in the papers we have been hearing, we have heard that most of the time the bipolar process which we are using, especially the longer time, they are revised in 5 years time. The motion seizures, and why does it happen? I will prove it to you now on the model and on this talk by the studies that we have made in Banaras University and the design that has evolved. Less degree of movement, stapler erosion after 5 years. We have got a survival rate of around 17 to 18 years with the inner preservation of movement of 30 to 15%. Arvind was there when this thing was being developed, isn't it? Polyethylene debris study. This is a very important call, friends. Please see that. Polyethylene debris study due to neck and cup impingement and thin layer of polyethylene causes early division, lack of positive eccentricity. It's a complicated word, positive eccentricity, who I'm using. Positive eccentricity is better with a 22 diameter head than a 28 diameter head that most of the bipolars are having 28. Even the international ones are having 28, but they have got the neck impingement problem. Sacrifice of calcar, you must be saying that when you use the other type of processes, the whole calcar is cut and the process is sinks on the cancerous bone and it sinks with the time. And polyethylene debris setting makes it a failure within 5 years. Now, so the rational design changes that has gone through the ellipsoidal outer cup provides extremes of the movement and does not dislocate. The patient can sit cross-legged and squat with the ellipsoidal shape of the outer cup. Trapezoidal neck. What we mean by trapezoidal neck, if you look at the other bipolars here that we are using, the neck is stout, round, and it reduces the overall range of movement. I will show you practically there on the table. And the neck impinges the poly. This is the #1 cause of the failure. And that is proved by this. When I copied this, I got a mail that you have not taken my permission to copy this, the impingement picture that you see that there. Have you got a pointer there? लोगों को बुला यार, अधिक से अधिक उसको मैसेज तो करने कर दूंगा, बाकी दो कहाँ जा रहा है? किधर से? ऊपर वाला? See, that is the impingement. Now, over the movement, when it is impinging all around, this much polyethylene debris study is sufficient enough to lead to fibrosis and stagnation of the movement and pain also. And if you do not use syringe, that also causes pain many times because of losing. Or now see the design here, that is the design change that has been made. The poly has been removed, so as in the extremes of movement, the neck does not hit the poly #1. #2, neck is like a hanging rope, that is the ellipsoidal neck, it's on the neck, and that gives more movement in abduction in all directions. So the movement is much better than even the international bipolar that you buy in 60,000 or one like 20,000. You can use this and charge your patients whatever you want because it is going to give you that kind of solidarity, movement, and painlessness. 22 diameter. Now, the second advantage point, if you use a 22 diameter, the 22 diameter will give you 8 years more life. Because if you are using a bipolar of 49 and putting a head of 22, the polyethylene thickness is more in a 22 head. So we have calculated on infinite meta-analysis that it lasts about 7 to 8 years more. So the no take-up impingement and survival has increased to 8 years more. And this was the design that we are using. And the second point that I will tell you, this is a series scan. You see that in this process is the thickness of the poly is more. Thickness of the poly is more. So this thickness for the same outer diameter, more thickness gives 8 years more life to your processes. 8 years is something that means. These are facts and scientific facts. Now, when we are trying this in the Pierre Banaras University Academic Forensic Department, we were trying to make the offset equal as the normal side. For that, how much to be cut? So friends, that is what has come in. You just cut one finger calcar, one finger reverse the lesser trochanter, and there is no need of modularity whatsoever. Both the limbs are equal, and we have done another paper with my residents. The offset is as good as on the normal side. So there is no variation in the offset, insignificant results have come. And the limb length is equal. For Austin Moore, you cut around 1.5 centimeter. For this process, you just cut 1 centimeter, and there is no need of modularity. Your limb length will become equal. This is the design. Now, I don't want to go into the mathematics of this eccentric offset. This is the called center in center. Like, if the two centers, if they are far apart, the inner ball will move better into the outer cup. And if you rotate if you see, the radius R for a 22 head will be smaller than radius R of a 28 head. And the inner head moves better if the frictional coefficient difference between the bone and the metallic outer cup and poly and the inner head is greater. The inner head will move better. So a 22 head moves better than a 28 head. This is the whole concept about lycentricity. The radius of the two don't coincide. If the radius coincide, they move like a unipolar. This is number one thing. And to see this video, that is how it should function in vitro. In the initial stage, there should be the inner movement at the right. If you see, do your operation and you look for it. Now when it will hit the cup, it is not hitting the cup, but the metallic part, and now the outer cup has started moving. That is how a bipolar should function. But if you use a bipolar which has got less 1 millimeter diameter, it is not going to work as a bipolar. It is important. Why? Because it as you will see in the next slide. And another point, if you use a bipolar which is loose, and that is what we have been told and taught and we are doing. When we take out a head of 40, we don't put 40, we go for 39. If we take out a head of 44, we put 43. That is not right. That gives a Hertzian contact stress that has been proved by mathematical calculation in the ITBHU, and that Hertzian contact stress makes all the time hugging in the scapula and wear, pain, and lack of movement with the time. So fibrosis, impingement, lack of positive eccentricity, and all these factors all together. So there are 7 advantages that you will see. And also, a snug fit cup gives less stress in the scapula. This is a stress calculation in a very high complicated mathematics. Snug fit gives the maximum stress into the scapula when it is put. In tight, we don't put a tight, but we do put a loose one, and that also gives about 18 megapascals stress in the scapula. And these are the papers. I'm not going to say that I'm going against total hip, because total hip is a answer for many things. When the scapula is rough, you have to do a total hip. I myself do a lot of complicated hips. But a unipolar, bipolar dislocation rates are almost equal, but the THR dislocation rate is very high. So wherever you can avoid THR and you can manage to use this, because that is suitable for your patient, cost effective, and good for surgeon and the patient both. And regarding reoperation rates, the unipolar has the maximum, THR and bipolar is almost same. This is a paper by Layton in 2010. And pain relief is maximum. You have done total hip and still your patient comes with pain because we do not give the proper version, proper fit, soft tissue management, etc. etc. So, if you are doing a lot of total hip and you are totally concentrated to total hip, fine. You should develop the skill in that so that you get a good combined inversion and you can allow your patient to sit and squat. Monty can allow his patient to sit and squat, but not he is doing only total hip and he has got the idea about how to do the combined inversion. But that is not, and many times I indicated vertical to dislocate, and I tell you posterior approach has got a more dislocation rates. Now 3,000 patients are operated between 2002 to 2002 when Arvind was there. Arvind, you were there in 2002 or you had left?
In 2006 to 9.
And then we calculated the movement of the inner bearing. People say that it becomes unipolar within no time. So there is a method by Duncan and Murray. By radiological method, of course, we are very gross. We can't have those gadgets and complicated, armamentarium. This is a simple radiological method by which the movements were calculated, that how much movement is there at the inner bearing. And with the passage, this is the graph. This has been done by the plow, and that showed that the inner bearing is still at the 12 years time. The outer movement was 80%, and no, the inner movement has gone to 20% down. So there was still preservation of 20% movement even at 12 years. It has not become bipolar or unipolar. Sorry.
You have intra video also, sir.
Yeah, I showed you. And out of 65%, here 35% at 12 years. Now, high pitch score I have taken by sitting and squatting. Dislocation rate was 1%, but that was surgeon, laxity or looseness or whatever, leg discrepancy. This is the number one question that in every conference I have not spoken and part in many conferences because this was a place where I thought that I must come and tell and share my views. The people talk about modularity. Modularity. Why do you need a modularity in a neck femur fracture? If your calcar is there and if you pat about your finger, the limb length is going to be equal. So why would you need modularity? Of course, if the calcar is not there, and limb is short, or it is an old one, calcar has resolved, of course you should go for a modular bipolar or total hip or whatever. But a fresh intracap fracture femur at the age of 60, that is the best answer, and this is the best situation that you don't need any modularity. You can cut the calcar 1 centimeter and you will get away with equal limb length, 99.9%. I use the lateral approach, and people complain sometimes lateral hardening, that patient gets an abductor weakness. That is maybe in some patients, but if you take a sliver of bone from the abductor center and put it back there is no abductor weakness at all. And you reduce the dislocation rate as well. And for total hip, for revision, for everything, the lateral approach is a lot better than the posterior. I know that people are more friendly with posterior approach here, even in India. Not everybody does the lateral. Most of the people, more than 50% surgeons, they do posterior. But in England, I think the posterior has been left only for doing posterior reconstructions. They go for lateral. And the lateral is very simple. You preserve the posterior 1/3 gluteus medius fibers and erase anterior 2/3 gluteus medius, because posterior 1/3 fibers of gluteus medius are pure abductor. If you preserve them, there will not be any abductor lunge. That is the concept of the lateral hardening. And I'm going to give you another concept, and here, take it, brother, don't worry for the version. When you are inserting your prosthesis, the way you read, that is how it goes. But there is any doubt, use your posterior collar of the prosthesis, which is parallel to the posterior border of the cut. Posterior border के parallel जाओ, और version is 100% correct. See, the neck is coming like that and going like that. If your posterior parallel to the posterior border of the neck is posterior, your version is 101% right all the time. We have done another paper on that with another chap. And that is what I am trying to show you. That make your collar of the stem posterior to parallel or co-linear. Co-linear is stem. Your posterior border. And your version is 100% right. In this situation, if you are fitting it, don't worry about any dislocation. you can allow your patient to sit on square after 2 to 3 weeks, provided you have used the cement when you are using the prosthesis. No problem at all. Posterior column. Posterior column. Posterior column. Posterior column. ये है एक यहाँ जमाई जा रही है पार्ट लाइन के यहाँ अगर आप हॉस्पिटल से बात करते हैं या पैसे बात करते हैं और इसके अलावा no worry for person. Even if it is shattered, it will never be confused. And then you stick back. Here I am showing you the lateral approach. This is the posterior corner, front of the gluteus medius, the lateral hardening. We reflect the whole front of the gluteus medius anteriorly. Now I cut the slide on a bone here. So when you put it back, the bone unites with the bone solidly. In the posterior approach, the bleeding is less, but there are certain chances of dislocation 4 to 5% higher than the lateral approach. I know it will take time to learn that, but it is good for doing total hip also. Well, I'm going to show certain cases on which people will jump. I'm not advising you to do that because I had to do that, and the patient wanted to sit and squat, and she was not able to afford the posterior hip. But this is the indication for this prosthesis, bipolar hip, fresh or old fracture neck femur in active elderly, where the age is around 60, okay, and that's it. So we do that after 15 years. See Miss Lahasi Devi from Gazipur, and well, I mean you can get that also with the osteomove sometimes. But what I want to say that it is not necessarily that you cannot do a total hip or your OT setup is not good enough to go for a hip replacement. You can give your patient a beautiful life sitting and squatting what your patient wants in this area. The question is कहाँ इलाज जो है देश काल पात्र और परिस्थिति के हिसाब से होता है. इंग्लैंड में उनके पास 1000 चीजें हैं. OT जो मांगोगे वो मिलेगा. अभी कर रहे हैं ऑपरेशन का दी आश्रम चाहिए तो आ गया ऑफ द लाइन. So our conditions are different. Now just I was discussing with Arvind that how many people come for medicine. As you are educating people, the people who are becoming more conscious about, so you are going for a hard thing, the fineness. And this was a lady who had gone 42 years, now the 20 years or 60. Maybe if the revision comes, you will revise it. But I am trying to show that that lady wanted to sit and squat. She had gone to Delhi and she was not able to afford total hip. So we did it after 15 years. She is from Jaunpur. And she's happy, no pain. No pain at all. And everybody will be jumped. Oh my God, what you have done? This is for total hip, only answer total hip. And you see, there is hardly any erosion there, even after 50 years, you see that, hardly there is any erosion doing the side. So, the movement is entering at the inner bearing. The inner bearing, we are going to make some changes to talking to the Nebula fellow that report the inner bearing with ultra 10 times less beer polyethylene. But it's not going to, it is going to last forever. And then, this is Mr. Right. This is a patient from worker, and he is a guy and a worker in the field. He is doing all the work, and this chap is going to the field, doing plowing, doing everything, all the household work in the house, no problem, 15 years down the line. And this was when we did it, it was a big row in the university at that time, and Punjab Singh he told Vice Chancellor that Dr. Rai, I should keep the name as Rai Bipolar. Well, I thought that no sir, people like to go for name. This is an institution. Mechanical engineering was involved, forensic department was involved, and many times our residents were also involved. So let us give the name to the institution. So it was given the name of the HF device at that time. Since that time, we are the patent was there, the name has been given, and we are. But unfortunately, I could not promote it. I could not educate people. I know that money, power is the greatest power. No, money lures you, every doctor, everyone. But the people who cannot afford that, there is an option for you. Don't go for crap prosthesis and don't go for 120,000 bipolar. because that has also got the same impingement problem. You can charge the patient whatever you want if you give the reject. So, this is what I had to say. I don't know how much people have understood it, and if somebody has to ask any questions, please go ahead and ask me. Anybody? Now I'll show you on the model here. And this guy, I'm telling him repeatedly that he stop making your crap now and go for it everywhere. But he is not stopping saying, though he said that he will be only promoting this. Now we look at it. See, this is your converter. Guys, you see that? This has a strong neck. And if it is 40 outer diameter, head 28, poly will be thinner. One. Second, every time it is hitting the body. This I showed you on the slide. That is the number one cause of failure. Third point, look at the angle. When you put it into the femur, you cut the whole lot. Hardest bone calcar is senior if you are using an uncemented one. And with a heavy patient, you start sinking inside. And Dr. Boacon used to say that it gives much more than they give into the bench there. However, when you use this device and you cut here, little finger, one, do it and see it. Limb length is equal. No need of any modularity. However, we can think about making the model into a doctor's preferred modularity. For inserting, this is a jig. You put it there, and you are putting it inside, you can rotate it and keep this posterior collar parallel to the line in line with the retrocanther anterior border, or the system parallel to the posterior cortex, cutting with neck tape, parallel right. And your buzzer is 101% dry. So, cutting the calcar here, little finger, and inserting, put कटे हुए लेग में नेक के पैरेलल इसको रखेंगे आप और regarding varus valgus, when you are doing this, most of the time you start entry from there. No, take out some soft tissue like pottery here, take your box scissor, and with the box scissor, बॉक्स सीजर से एकदम लैटरल से काटिए और उसको भी पैरेलल रखिए, ऐसे नहीं, पैरेलल टू दी कैलका, और बहुत फाइन ब्यूटीफुल एंट्री वहां बन जाएगा। इसके बाद टेक योर रिवर कहाँ है जी, वो कहाँ गया, रिवर कहाँ गया, रीम कर दीजिए। अब क्या करोगे, यहाँ काटने के बाद सब लोग करते हैं, ऑस्टियोमोर बाइपोलर एवरीबॉडी इज डूइंग, so that is the reason, so that you can centralize it. When you are using the cement, please don't forget to use the restrictor. Why? Restrictor का cost बढ़ जाएगा 2000, नहीं डालना चाहते हो डालो, सीमेंट डाल के you can go ahead directly, इसके बाद बहुत ज़्यादा चलना नहीं है, 60 साल के आदमी को 15 साल 20 साल 25 साल यही भी चलेगा, पर restrictor अगर है तो अच्छी बात है। रेस्ट्रिक्टर को वही लंबाई 18 सेंटीमीटर, आपने रेस्ट्रिक्टर डाला, निकाल लिया, put your cement, you have already ringed it, take your prosthesis, put this thing there, like that, ये आपको वर्म कंट्रोल करेगा, and then you go inside and turn it parallel to the lesser trochanter के interior border के, जहाँ lesser trochanter के साथ यहाँ मार्क कर दिया आपने कॉटरी से, और फिर lesser trochanter के पैरेलल इसका posterior border जाएगा, एक yes, इसका posterior border इसके कंध, not worry about any work, it will go in. ठीक, अब इसके बाद sizes, you have got all the sizes. If you take out a head which is measuring 40 or maybe 44, normally what you do? Normally what you do when you do osteomolar and bipolar? What do you do? 43? 43? No. 43 is not going to work as a bipolar. You must use 44 because you saw the slide. There is a minimum stress if you put the same diameter, number one. Number two, this with the muscle forces, this remains stuck with the sternum and only inner bearing moves. तो इनर माइनर में ही मूवमेंट हो रहा है। एक्सट्रीम में जब आएगा when it will go there, बैटरी और बात मारते समय, then the outer will move. And this bipolar will not dissipate voice because पहले आप हाफ सर्किल ये जब इसको लगाते हैं आप, ये स्टब्लर में सिंक कर जाता है और स्टब्लर में जब सिंक कर जाएगा तो देयर इज चांस, एक तो पॉजिटिव अप्रोच कर रहे हैं आप, दूसरा ये सिंक कर गया तो ये चांसेस हैं कि फटक जाने का। Here, because the cup is spiral, it is hanging out. The stapler is not half circle. It is hanging out, so it stayed in. It stayed in. Even in the extremes, there is something there to support and hardly dislocates. And then the gross movement. Look at the gross movement. It goes there, tap, 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 tap. Clear is it? You not fineness of any this tap should not be there. It gives a Hertzian contact stress. So this is the gross movement there. If you look at it, the gross movement is more. If you look at it, we have measured that. We have measured that. We have measured that. This gross movement is more, and this is more than even if you take the international. If the BFP people are here, they can compare it. The gross movement is more than the international one, because international one how to have यहाँ लाइनर यहाँ तक आ रहा है प्लास्टिक का, and that slide you saw, the neck up impingement. When this came out, they took away from me, kept this prosthesis for 2 years in Manchester and Leeds. Finally, they told me when they will launch it in India, they will launch a cheap bipolar, they will take up this one. But in fact, I should have done the case with those साल तक उन्होंने मुझे मना कर दिया, और कहा चाइना में मत बोलिएगा और कहीं बोलिएगा मत। 2 साल तक I was made stagnant not to speak about it. But anyway, somebody has not been there. So यही सब बताना था मुझे। ये इसका ऑक्सीजन है, ऑक्सीजन लेंगे, आपने खोला पॉस्चर करें ये, इसके पैरेलल लीजिए, पैरेलल यहाँ पर तो थोड़ा सॉफ्ट टिश्यू हटाना पड़ेगा, and your processes will never go in balance. You make the entry from there, यहाँ पर नेक कटी हुई है, नेक के पैरेलल रखिए इसको, नेक के पैरेलल रखिए, and then you go straight down, and your slot will be made parallel. And then you take the centralizer, reamer, and then you put the processes. Again, by keeping the calcar, and when you put the calcar, cut off over, calcar के rear border है, and rear border के parallel, उसके process border को collinear कर दीजिए, no problem. On table, you can test it by putting cross again, by doing some rotation, so that the patient is not disturbed. A similar test should be done for even total hip. When you are doing a total hip, and there is a problem, you can change the version. What I asked the question, you can change the version, height degree, 10 degree, retro entry. You can make it the history accordingly and make the total combined version 40. SW or NECTA combined version 40. Now, rats, they have to provide the rats. Nebula people are manufacturing it. The rats are two, one for cemented, one for uncemented, or any rat. You can try yourself. There are 2 varieties of the prosthesis. One is uncemented one, patient is not able to afford. But in a porotic patient, I swear to you, if you use a cemented one, you will be very happy. इन करके रेस्टिंग का डाल दिया, सेंट्रलाइजर की जरूरत नहीं है, और हमने डाला इसको और पेशेंट को थर्ड डे पढ़ाया, and we not have any pain except a little pain of surgery because the prosthesis is very stuck there and there is a free movement there. So don't use this thing. But if you are using uncemented, patient is not able to afford anything, go for uncemented. But in ladies, अनसीमेंटेड से बढ़िया सीमेंटेड यूज करना बेहतर है, 2 कारणों से। कभी कभी उनकी ब्रेन कैविटी को ध्यान होती है और शुरू में खा के नई प्रोसेस डाल रहे हैं, कहीं फेंक में जा रहे हैं अनसीमेंटेड। बट सीमेंटेड इज वेरी सेफ। मेनी टाइम्स इट हैपेंस दैट यूजिंग इज सीमेंटेड एंड यू डोंट वांट टू यूज सीमेंट, टेक आउट द हेड, ग्राफ्ट इट एंड टेक इट। If people are going to survive 10, 15 years, 20 years, why should you leave the water there? Why should you go for total aid? That's one thing. From your yeah. अच्छा, अब finish? Finito? Yes, sir. This time, they have to use that impact here. ठीक है, दूसरा होता है, अच्छा हाँ एक और इम्पैक्टर है, इससे भी लगा के आप कर सकते हो कंट्रोल, they are body producer, ठीक है? अच्छा neck cutting तो ठीक है, one finger, don't go for the jigger on that, one finger, just one finger, middle finger, partially got to cut. Any questions, friends? आज मैं बड़ी खुशी हुई कि मुझे उस ढंग से मैं बात कर रहा हूँ, जिस तरह से बात करना चाहिए। कोई सवाल पूछिए आप लोग, मुझे मालूम है everybody wants to do big things, great things, ये वो, इससे हमारा अहंकार होता है, I hate this. But simple things, if you can do it nicely and help your patient earn your money, वो उस पर भी लोड हम लोग होते हैं। आएगा पेशेंट आपके पास कहेगा give me the best, आप कहेंगे we ask him for the best. So if you buy me 1,20,000 or 1 lakh rupees, if you give us this or 65,000 like wow, do it sir. You charge it, do it. It's going to cost the same way, much better than that. Why? कोई सवाल और पूछना है? यहाँ संतुष्ट हो रहे हैं कि नहीं? लोगों को तो केस किया हुआ है मैंने सुप्रीम कोर्ट में, अभी तक केस नहीं लग रहा है। क्या केस है? Because they holded me for 2 years not to speak about it. और जहाँ पर आपको लगता है कि आप पेशेंट नहीं अफोर्ड कर रहा है, डरिए मत, डर ही के आगे तो जीत है। नहीं या कि आप मुझे सारा जीवन टोटल ही बहुत है, सारी दुनिया बोलती है टोटल ही करना है। अगर स्टेबल में जरा भी स्पेस दिख रहा है, थोड़ा वो है, put a cement, you will be pain free, walk, sit, squat, or unless you create the things. So because in England, how many of you have operated tennis elbow? How many of you have operated tennis elbow? No? No? How many of you have operated heel pain? No? तो टेनिस elbow का ऑपरेशन यहाँ नहीं होता है, ऐसा हो रही कि हमारे जमाने नहीं होता। जिनके पास काम नहीं है तो वो टेनिस elbow करेंगे ना। हाउ दे विल जस्टिफाई भाई ऑर्थोपेडिक सर्जन निकाल दिया जाएगा, मिस्टर हाउ को निकाल रहे थे सब, ये काम नहीं कर रहे हैं, कुछ काम नहीं कर रहे हैं। So they do operate. टेनिस elbow is a self-limiting disease and disappears in 2 years' time. But again, if the patient is there, try to deep on the ground. If you fail 2, 3 times, you are most justified to do that. How do we operate tibial posterior syndrome, which is less disease? Patients are the same. In England, after 50, people come with, ladies come with the pain, sinus starts syndrome, a lot of them. What we do? We give it a medial arch and they are happy. If not, rarely, deep-bone, if not, then they operate, do the seat removal, close it, patient is happy. तो देश काल पात्र और परिस्थिति उनके साथ तय होगा। तो उसमें मुझे लगा कि जब मैं आया था इंग्लैंड से तो मुझे लगा हमारे यहाँ बात होने लगी, लोगों ने कहा कि साहब भाई पूरा तो फेल हो जाता है, 5 साल में ऐसा हो जाता है, ऐसा हो जाता है, शायद ठीक नहीं होगा। और इसके बाद जब पढ़ा भी नजर में तो समझ में आया कि इसको ऐसे करना चाहिए। एंड नाउ कैन डन इट्स लाइक नाउ 20 years, अब तो पेटेंट भी हमारा खत्म हो जाए तो सारा पकड़ के बना they will do that. But doesn't matter. My only appeal is that please try, because we have got all the gadgets, all the numbers. Whatever number passes on, जो नहीं जा रहा है और जो ड्रॉप कर जा रहा है, जो डिफिकल्टी से पार हो जा रहा है, वही साइज है. Go for that. You can put a tight one and you'll be happy, rather than a loose one. You are scared. Tight डाल दिया क्या हो जाएगा? Okay? चलो भाई,
माइक
इसको दिखाना था काटने का, कहाँ कार्टून मॉडल? ये तो है, कार्टून तुम्हारा मॉडल है। लो लो मार्किंग पेंसिल, मार्किंग पेंसिल है, 2 मिनट आगे तब यहाँ से आए हैं मॉडल तो कुछ दिखाई नहीं, यहाँ पर मार्क करेंगे आप। आएंगे कुछ नहीं, ये कैंडल का जो ये रहा लेसर पेंटर का इंटीरियर वॉल, ठीक है। इससे ये तो हमको इसके लिए यूज कर रहे हैं, जब हम प्रोसेसेस डालेंगे तो इसका पोस्टीरियर बॉर्डर इसके लाइन में रहना चाहिए, इस मार्क के लाइन में ऐसे जाएगी, ये पोस्टीरियर बॉर्डर, ये वर्जन सही रहा, अंदर जाएंगे तो इसका पोस्टीरियर बॉर्डर इससे फ्लश कर देंगे। ये तो आपका होगा सही हो गया, नो डाउट। और रिगार्डिंग ये about quarter centimeter. Angle दिखाइए, या your little finger above it. Put it there and close कहाँ ये मार्क, यहाँ पर आपने मार्क कर दिया, ये मार्क कर दिया, लंबाई की बात ये मार्क कर दिया आपने यहाँ रखा, और यहाँ ये आपने कहा गया मॉडल आपका वो सॉफ्ट आ गई, ये लिया, यहाँ पर तो इसके नीचे आएंगे पकड़ो, निबल से लेने में ज़्यादा करता है इसलिए अब यहाँ पर कहाँ गया बॉक्स, यहाँ पर सॉफ्ट टिश्यू होगा, तो सॉफ्ट टिश्यू हटाइए और यहाँ के पैरेलल जाना है, यू टेक दिस वे पैरेलल टू द पॉजिटिव कॉर्नर्स, ये है ना पॉजिटिव कॉर्नर्स, ठीक हमें इसके पैरेलल है निकलेंगे, posterior body के पैरेलल, yes, sorry नॉर्मल एनाटॉमी में ये जो हम जा रहे हैं ये इसके पैरेलल जा रहा है, इंटीरियर की हम परवाह नहीं कर रहे हैं, वी आर नॉट बॉदरिंग अबाउट द इंटीरियर, वी आर गोइंग पैरेलल टू दिस, तो जब इसके पैरेलल हम काटेंगे तो वी आर वर्जन इज करेक्ट, क्योंकि नेक आकर के ऐसे नहीं हो रही है, दैट इज होल कॉन्सेप्ट। तो अब इसके बाद इनका वो नहीं कि एक फिंगर रखा काट दिया, वो तो रिंग करने रखा, रिमर नहीं रखा, हाँ खराब हम क्या करें इसी से डालते ये इसको डालते समय लैटरल के पैरेलल, जब आप लैटरल एंट्री लेंगे कोई चांस ही नहीं गड़बड़ होने का, और अगर लगता है कि लैटरल कम है तो थोड़ा सा और काट लीजिए, आपका बहुत कोण है, यू विल नेवर मिस, यू विल नॉट गो लैटरल, ये थोड़ा यही कॉन्सेप्ट टोटल हिप में भी है, इफ यू मेक द हिप अब हुआ, अब ये लैटरल हुआ, तो हमारा कोण यहाँ है, इसके इधर नहीं जाएंगे, यहाँ से जाएंगे, यहाँ हमारा सीधे कैनाल भी जाएगा, और ये लैटरल हमने पैरेलल किया इसके पैरेलल, इंडिया के बारे में बॉदर नहीं किया, और आप यहाँ पे जब घुसेंगे यहीं तक करना है, इसका काम यहीं तक खत्म, इसके बाद रखा है इन लोगों ने रीवर, टेक द रीवर, गो इनटू द मेडोनी कैविटी, और उतना ही लंबा है, अच्छा, देन यू यूज लोड योर, आपने रिम कर दिया, सीमेंटेड करने जा रहे हैं तो ये इसका अप्रोच है, उससे खूब रिम कर दिया, प्रोसेसेस लिया आपने, प्रोसेसेस लेके देख लिया, प्रोसेसेस ढीली है, लूज है, फाइन, वी आर गोइंग टू यूज सीमेंट नाउ, इफ पॉसिबल यूज सीमेंट, डोंट गेट स्केयर्ड ऑफ सीमेंट, सीमेंट करके आप करेंगे प्रोसेसेस, आपका मरीज बहुत सुखी रहेगा। पेन जो होता है हमारा इंटीरियर पेन, थाई पेन, दैट इज बिकॉज ऑफ द मूवमेंट ऑफ द स्टेप इन 2 to 3 years टाइम। ठीक ठाक पेशेंट है, लग रहा है, पॉसिबिलिटी नहीं है, सीमेंट नहीं है, गन आपके पास नहीं है, तो भाई नहीं बना के आप डालेंगे, पर डरता है आदमी ओटी में जाएगा, लेकिन नहीं होता तो सिंपल अनसीमेंटेड यूज करिए, अगर अनसीमेंटेड टाइट पड़ रहा है तो सीमेंटेड ही यूज कर दीजिए, अनसीमेंटेड की तरफ बोन ड्राफ्ट डाल दीजिए, हेड निकाला है आपने, हेड पैक करके करते करते जब इसका कॉलर पहुंचेगा, इसका कॉलर पहुंचेगा यहाँ तक, ये जैसे ही जब कॉलर पहुंचने लगे यहाँ तो आपके पास ये जिग है, जाएगी उसी में, आप लोगों ने बहुत किया होगा, कोई बड़ी बात नहीं हो, जब इसमें जाने लगेगा तो थोड़ा सा इसको थोड़ा ऐसे कर दो, और ये जाके बैठ गया, सॉरी सीमेंट डाला है, अब आप रेड्यूस कर दो। रिडक्शन करने के बाद आप मूवमेंट टेबल को चेक कर लीजिए, रिडक्शन, एक्सटर्नल रोटेशन, जो कि मरीज आपका बैठता है आती नहीं मारता टू दैट फैसिलिटी। अच्छा, ये अपनी बात याद रखिएगा क्या क्या लेंगे, क्या लीजिएगा और फिर करना बताना पड़ेगा। ये लोग ऐसा बनाया कि लोगों सजेस्ट किया है कि ऐसा क्यों बना रहे भाई। इसको जब दो तरीके के जिग हैं, एक स्क्रू वाला है, एक डायरेक्ट ऐसे हैमर करने वाला, जो चाहो आप इस्तेमाल करो। रैस्प जो आप इस्तेमाल करते हैं ऑप्शन मूव के लिए, उससे भी आइडिया लग जाएगा। हालांकि इसका रैस्प है, दो रैस्प हैं इनके, सीमेंटेड अनसीमेंटेड। तो ये रैस्प है, तो ये रैस्प का सीमेंटेड का हुआ, ये सीमेंटेड का हुआ। मोस्ट ऑफ द टाइम मैंने ये देखा है कि काम करते समय आपको ईजी पड़ता है। सीमेंटेड वाला जो है ना ठीक ठाक बढ़िया जाता है, लूज हुआ कोई बात नहीं, वो ड्राफ्ट डाल के डाल दीजिए। नहीं सीमेंट है, पेशेंट में अफोर्डिंग यूज सीमेंट रेस्ट्रिक्टर लगाएंगे, 2000 दाम बढ़ जाए। क्या आज मैंने वाकई पहली बार इनके तुम्हारे थैंक्स टू डॉक्टर एन के सिंह who provided me this opportunity, because this academics is also, I tell you frankly, there is some kind of politics everywhere. Sorry to say that.
Thank you, sir, for this nice presentation, sir. And I would like now Dr. Arvind Prasad Gupta, sir, to facilitate our sir, Dr. Anil Rai, sir. And I also ask Dr. N.K. Singh, sir, to come on the stage, please, sir.
तो ये पेपर है जो पब्लिश हुए हैं,
यस सर,
वेरियस नेशनल और अपने आईओए में भी पब्लिश हुआ है ओरिजिनल ऑर्डर। और 2017 में विजय कुमार ने भी बोला इसके बारे में, वाराणसी All right. I am very proud to see Arvind here and doing such good job, and he was holding the whole session, because when he was the resident there and we were doing an orthoscope, there was an old orthoscope, जिसमें पानी डालते थे, किधर से निकालते थे, किधर से पता नहीं चलता था।
Sir has given me the thesis topic of orthoscopy. That was the beginning of orthoscopy. That time it was the least done surgery at KU. But only because of sir I developed interest in orthoscopy. And again, thank you very much, sir. And Dr. N.K. Singh sir also is from BHU. And I think you both were the batchmates.
See, he still looks so young, you know. मुझे पूछता हूँ कि what is the secret of the youth? बिहार से है ना, हम नहीं बिहार में अपनी बात कहेंगे तो कहाँ करेंगे?
sir, for the